Good afternoon, everyone. This is a pleasure to be among you this afternoon. We are sitting here in North Bay and have many of our staff, our senior team especially, sitting in Sudbury and across the Northeast Lynn. Many of you sitting around your phones and listening today. It is a pleasure to talk to you. I am Jeremy Stevenson. I'm the new CEO here at the Northeast Lynn. What a better way to start. I've been here less than 3 months, but what a better way to start by kicking off a strategic plan as a new CEO. It is an honor to be involved in this process. It's been a process that we hope to do things a little bit differently. As we present today, it's a formal presentation, but we do want to keep it informal somewhat. We want to go through a slide deck fairly quickly, give you a bit of a current state of affairs and open up for your input. But again, first of all, I just want to highlight a few things. Those around the room, we want to thank you for taking the time for joining us today. This is, again, it's a kickoff. It's a beginning process. I have my entire senior team on the call, too, to assist and answer questions also and to participate on this call. To my right here today, I have Cynthia Stables, who will help me with the presentation. She has been very instrumental. We're very lucky to have somebody here who has been involved not in one but from the very beginning, putting these strategic plans together, which are called integrated health service plans, for those who don't know. And they're typically 3-year plans. When we say we want to do things a bit differently, we hope to see things evolve and even be, I guess, more different and more integrated in 3 years from now. But at this time around, I want to, what we'll talk about in slide 16 is we've wanted to make sure that we hear first and foremost from those that are at the front line, so who see what can be improved, who see what's going well. We wanted to make sure we had a steering committee that was led by many of you, representation across the region, from sectors, from specialties, from experts, and have some patients also involved. So this steering committee, you will hear a little bit more about it through the presentation. We've had our first meeting with them to help them guide us in this process, and we will be talking about that this morning. So maybe to start here, I will walk through some of the slides. We don't want to spend too much time on the slides, but really wanted to set the tone with you and the many health service providers around the Northeast and the Northern Ontario who would help us to provide more input on not just the process, but also we'll have some specific questions for you. To be very clear and frank, at the end of the day, we're not looking to change everything, but we are looking to make an impact. And what we say by impact, we want to make the biggest impact. We are focused. We want to be focused on what matters most, on the priorities. And you often hear those words come out of my mouth, and some may get tired of it, but that's what we hope to do. We want to come back with concrete priorities where we can make a difference, where we can have an influence in the system with you hand in hand, where funding will go, where resources can go, and where improvements can happen, integration planning, system planning, and at the end of the day, the best service delivery, because it's all about the people who we serve and the people we care for, our patients. So with that, for those that are maybe new, the second slide that we have presented with you today is just a quick glance of who we are. I don't think it's news to anybody, but we represent a large region. We often use the example of being larger than a country the size of Germany, with 562,000 people and a budget of over $1.5 million for healthcare. So we are a big LHIN. As of May 1st, we represent a greater team, now also delivering, not only just doing healthcare system planning, integration, and funding, but also delivering the care through home and community services, which sees about 17,000 people receiving care from us. Our staff is a staff of about 700 people across many sites. We have small sites, satellite sites across the Northeast Lynn, some of our smaller communities, and we have some larger sites in the bigger cities. That's important for us. We want to be visible. We want to spend more time with Northerners. It's something that we find challenging with our size, but we're finding ways, and this is part also of this exercise through this community engagement. On slide 3, just a little bit the process of the When you hear the term IHSP, it stands for Integrated Health Service Plan. It is our strategic plan. We hold this exercise every 3 years. It is a process that is very aligned with the ministry. Our 14 other LHINs in this province do it also at the same time for the same amount of years, and they do provide us some direction to make sure that we are well aligned with our colleagues, with the ministry, but more importantly then aligning it down to you and to the patients. So those 3 bullets there: identifying priorities for health system transformation efforts, that the IHSP will lead the direction for local health system, and also targets investments over the 3-year planning cycle. On the 4th slide, I just want to draw your attention to the bottom of the slide and what it means to us. One thing that you'll hear us often refer to is the alignment across the sector. When I say, we may see things a little bit differently, I'm hoping in 3 years that this process will be done at a sub-region level, to be very open and frank. And I want to hear from you on that as we go and meet with many of you today or throughout the summer months. But what I'm saying about that is, we are all developing strategic plans, and I have an opportunity to sit on a few health service providers' strategic planning processes and making sure that we're aligned and they're aligned with us and we're aligned with them. We have over 150 providers of care across our region, so it is a challenge. And how can we be better aligned and maybe better integrated when it comes down to strategic planning? So we are meeting directly the needs that many of you offer, and vice versa. So that's what that bullet that in red at the bottom states, and how we can be better aligned. On slide 5, it's really we just wanted to touch upon briefly what's changed since the last plan. Right now, as you know, we're in our last year of our strategic plan. You will hear much from me as I go in the communities, sharing a bit of our vision and my vision and our direction, what we hope to achieve in this last year of the current IHSP. So it's very exciting. We have those 7 concrete priorities that we're focusing on, and you'll hear more about them. But what's really changed since then is we've had the Patient First Act that came out in 2016, and it brought some changes in healthcare. So I thought we'd just touch upon some of the report on some of the achievements since the last time, and since this Patient First came out, and how it's shaping our new strategic plan. So the first one, as many of you know, we'll be hitting in a few weeks right now, the expanded role of the LHIN when we transition home and community care, which used to be called the CCAC, the Community Care Access Center Services, and their staff with the LHIN, which came some great savings in administrative, and I think we don't want to stop there. We want to continue building on that success. You've seen physically the linking of primary care and care coordination and care coordinators. What a fantastic initiative. We're seeing many of our staff embedded in the community, and not just in primary care. I can venture and say we want to see them embedded more in the community, mental health, in hospitals, in primary care, and family health team, community health centers, and more. And we hope to work with you to make that a reality and bring that link in closely with primary care. Stronger links with public health. We meet with them on a quarterly basis. Actually, I meet with them on Monday for my first meeting. And one of the initiatives that's written here on the slide deck is Stay on Your Feet, the falls prevention. A lot of that success comes from that strong partnership with public health. So we're looking forward to building on that. And just on the side, a bit ad lib, it's an opportunity for us to look and say, okay, how can we look at prevention and promotion? How can we look at the more vulnerable people in our society, in our community, before they get to where they get? So I look for their support and expertise to help us to improve the system transformation. We have now what the acronym here is PFAC. It's the Patient Family Advisory Committee. 18 strong members from across the region, from different backgrounds, different expertise, ages, languages. Some of them actually serve on our steering committee for this engagement process. We're pleased to say that we've had our first 2 meetings. We're having our 3rd coming up soon, and we'll be meeting on a quarterly basis with them. And just let me speak briefly to what we hope will be the strength in this one difference and strength in this IHSP is the word equity. We want a stronger voice for the North. We want that care delivered anywhere in the province is the same in the North, and we don't feel that is the case. We're very lucky to have a Northern Ontario Health Equity Framework strategy that has just been developed through HQO. You'll receive copies of those shortly, and we will be building a lot of our cases around that good work. And lastly, I just want to commend on the great work that we are seeing on what I call drilling down, bringing healthcare more local. The L in our LIN, what it stands for, and that is building around our sub-regions and our collaborative tables and our care communities. So as we come out in the communities, we'll be referring to those. We will be developing through our new IHSP how we can deliver care more locally. So I'll turn to Cynthia now. As I mentioned, she has been involved in the last 4 years. I'd like to give her more credit than is deserved for all this work, and maybe I've asked her for that reason to walk through the remainder of the deck.
Thanks, Jeremy. So I will, I'm committed to ending at 3, if not before, so we have plenty of time for discussion and the lines get opened up so you can tell us what you're thinking and feeling about healthcare today and going forward over the next 3 years. So as Jeremy mentioned, we're kind of saying sub-region/care communities these days. Our sub-regions, there are 5 of them. There are old hubs. And we, through the work of Terry Tilichuk, our VP of System Planning, and Dr. Paul Preston, our VP of Clinical, a lot of work is happening within our sub-regions to essentially better understand capacity and working with our 14 collaborative tables and ensuring that we have the gaps identified and the strategies at a local level identified as we go forward. We are applying population health and health equity principles to recognize the unique needs of each community. And through the work of Dr. Preston, we have identified about 35 care communities, which I'll speak to in 2 slides. The next slide really is speaking to why we are focusing in on our sub-regions and our care communities. It's because right now our 560,000 some odd Northerners are navigating all kinds of sectors of care. It's it's not a very integrated system by any stretch of the imagination, and we're trying to get to that point. What we are trying to get to on the next slide is our vision. It's a care community vision where you see at the center, we're calling it a Northerners medical home, where we have, as Jeremy said, primary care and care coordination working hand in hand. Our care coordinators and the work of our VP of Home and Community Care, Richard Shawley, is really coming together to ensure there's embedding and closer linkage between those 2 areas. This summer and perhaps for the rest of the year, Dr. Preston is going to be going out and engaging with communities and trying to establish which of these rooms in this house in each of those 35 communities are empty, and what do we need to do to fill them up. Really what we'd like to see is capacity that will allow communities to have social work, mental health and addiction, transportation, seniors care, physio, and everything else you see within this home. We know right now there are gaps across the system, and it's safe to say that people living in Wawa are likely not receiving the same amount of care or having access to the same amount of care as someone in North Bay or Sudbury. And we want to change that as much as possible so people get care close to home, and that is our equity lens that we will be applying to this IHSP. The next slide is our current priorities that were developed to see us through from 2016 to 2019. Many of you will have been involved in establishing those priorities, as we did many engagements 2.5 years ago now, or maybe 3.5. So we have improved access and wait times, enhanced care coordination, and strengthened system sustainability. As you'll see in the next couple slides, which I'm not going to speak to in great detail, the importance of our priorities is that everything we do as a LIN over the next 3 years, we will hang our hat under one of these priorities, whether it's an investment, whether it's a decision that needs to be made, whether it's about building capacity, we always try and link back to our priorities. And so if I go to the next slide, you'll see these are just some of the things that have been done to improve access and wait times over the next 3 years. And I won't go through them because there's a lot there, and there's even more behind this slide, but it gives you an idea. I'll perhaps just point out we're proud of the work that's been done on our opioid strategy. I think you'll see over the next couple of weeks some announcements on opening up RAM clinics, and a lot of work has been done with our Regional Mental Health and Advisory Council. On the next slide, enhanced care coordination. A lot of work has been done in that slide. Richard Jean-Luc could speak more eloquently than I could about One Client, One Plan project that you see under the home and community care bucket, and the work that he and 70 home and community care providers are doing to bring the system together so that patients and Northerners can be assessed far less. In fact, once would be nice, and have one telephone place to call to get the care that they need as they try and live at home safely. The next one, strengthen system sustainability. That's the third priority that we've been working on over the last 3 years. Jeremy mentioned the Northern Health Equity Strategy that we worked on with the Northwest LHIN, HQO, public health units. We're proud of our Aboriginal Health Reconciliation Action Plan and the work that we do hand in hand with the Réseau du Mieux-être francophone du Nord de l'Ontario. And last I saw, there were a couple of our partners from the Réseau on the line, which is great. So the next slide brings us to where we are today. We're about to start what we're calling IHSP5. It'll take us from 2019 to 2022. Because we're in this funny period where a provincial election is going to be called or the writ will drop in a couple of weeks. On May 9th, we will abide by the terms of the writ period as a Crown agency, and you won't hear us publicly speaking about your health, your voice, your Northeastern Ontario plan, that tagline that we've come up with. But we will be speaking with you, and we hope that after this call, I'll be able to receive a few emails about some opportunities to further engage with you. And then over July and August, we will go out and do more extensive community engagements and launch a survey with Northerners. The next slide, this is the process that we're using to develop our IHSP, and anything you see on these slides, we're very happy to receive feedback on. It's a pretty rigorous process, and it is fairly directed, actually heavily directed maybe, from the Ministry of Health. So the blue part, we consult the provincial and policy documents. We also are looking over the engagement outcomes that we've done to date. There's thousands of people that we've talked to in the last 10 years as a LHIN. We're mandated to engage, so we do actively do that. We have it all documented, and oftentimes, sometimes not too much changes in terms of what people wanted out of the healthcare system 5 years ago versus today. But the landscape has changed a little bit with Patients First, and as Jeremy said, we now are a deliverer of home and community care services. We have a stronger alignment with the public health units, and with Dr. Preston, we're working more hand in hand with primary care. So the landscape has changed, and we want to go out and ask people once again what they want and need. Jeremy talked about establishing our steering committee. We met 2 days ago for the first time. We'll meet monthly. You'll see in a few slides the entire system, we think, is represented around the steering committee, and it's going to help to guide our process to make sure that we stay intact. There is an environmental scan and a lot of data analysis that is taking place right now between all 14 LHINs and the ministry, and we will be receiving a very comprehensive environmental scan at the end of June, which in good time we will post to our website and use in our engagements when we go out this summer. Over the month of, so I'm on to the brown part of this wheel, over the months of May and June, during that quiet time, the writ period for us, We will be engaging with system partners. We will be going out to the 14 collaborative tables and having a conversation with them. We know they've done some extensive work to set priorities and look at gaps within their particular areas. We want to build on what they've done and ensure that it helps to inform our overall plan. And as I said, we're very happy to engage with you further and have a good discussion with some of your tables if you feel the need. We're hoping to come up with draft priorities by the end of June so that we can validate those with Northerners throughout the summer. And we need to have our IHSP5, our strategic plan, written as a draft and approved by our board by October 31st, and then we'll publish it by February 1st of 2019. I just have 3 or 4 more slides. So we know that our IHSP, this is the directive that has come from the ministry. It was in an ADM, a memo from the ADM to all NCOs back in March. We know what we need to include in our IHSP. Certainly our priorities for the next 3 years, our strategic directions for our LHIN-delivered services, which are home and community care. Our strategic directions and plans for each sub-region need to inform and be visible in some way throughout our final document. We need to use a population health perspective. This is different. This is part of the changing landscape and speaks to Patients First legislation and our more proactive work with health units. We need to ensure culturally appropriate sub-regional planning that engages and addresses the needs of high-risk and marginalized populations. And we need to have full and robust engagement with everybody that's noted there. We will work hand in hand with the réseau to ensure the francophone voices are around the table when we go out, and we will be working with our local Aboriginal Health Committee to ensure we engage appropriately with Indigenous Northerners. And the last thing on that slide, again, newness in this IHSP, we want to be sure and have to be sure that health equity is a clear priority going forward in some shape or form. The next slide, this is the steering committee that we've referenced a few times. You'll see on the right-hand side in the purple everybody who's sitting around the table. We have a couple members from our board. We have public health, the réseau. We have long-term care, health system advisory group, mental health and addictions. Our hub hospitals are represented. So if one of those individuals is working in your organization, you can go up to them and speak to them about the IHSP and find out where things are at as well. The next slide, this is a lot of work that's been done under Jeremy's leadership just over the last 2.5 months. I'm sure it seems like it's been a year since he's been here, and when I look at it, it's only been 2.5 months. But it just, we actually call it priority alignment framework because it's helping us to ensure that everything that we do is aligned with the Patients First legislation, is aligned with where the province is going today and tomorrow, the patient experience, access, integration, health equity. It's aligned with the mandate letter that the minister sent us last May, telling us what we need to deliver on this year. And you'll see 6 things there. Many of you will have seen, that last year or for this year, we renewed our strategic direction, which really centered on the need to improve the health population by building capacity. So we've put a concerted effort into capacity planning and capacity and analyzing further the gaps that are in the system to help us get to where we need to go. The light pink that you see there, this is what we as a senior team are really focusing on this year. We've identified 7 concrete local priorities: capacity, mental health and addictions, home and community care, primary care, digital health, French language services, and Indigenous health. That's where we're focusing on right now. Those of you, if you've been paying attention to the reports that go to our board, they center around these 7 priorities. Our annual business plan is focusing on these, and it is in alignment with our 3 current IHSP priorities I told you about at the beginning. Our desired outcomes, I'm sure, are very similar to yours. We want to improve the patient experience, we want to improve the system performance, and we want to improve population health. So this is the last slide, and is 258, which is great. Interested to hear from you today. Anything that you hear or have seen on the slides, what you think, what you feel is great. As Jeremy said, our senior team is in Sudbury and on Northern Roads right now, and we're all prepared to answer questions. When we go out in July or at the end of June, once we get out of the RIT period, we will be asking system partners, do our 2018-19 local priorities resonate with you and your vision for a strong Northeastern Ontario healthcare system? And in other words, if we focus on building capacity, mental health, home and community, primary care, everything you see there, is that where we should be focusing? Tell us what you think. And the second thing we'll be asking people in order to build our next IHSP is, do our current 3-year priorities need to change to reflect what Northerners need to live healthy and well over the next 3 years? Should we continue to focus on improving access and wait times? Should we continue to focus on enhancing care coordination, strengthening system sustainability? Or do we need to change? Do we need to tweak what we have? So that is the end of the deck. I think what I will do now, unless Jeremy's good, so no need for closing remarks because we really want to get into a discussion.
Thank you. And ladies and gentlemen, the floor is now open for questions. If you would like to ask a question, please press *1 on your telephone keypad. Once the operator opens up your phone lines, you will hear a message that your line has been unmuted. At that time, please state your name and ask your question. And I'll turn it back to Jeremy and Cynthia as we're waiting for calls.
So it's not just, I know we're saying questions here. I'm listening, I guess is what I'm saying. I appreciate all the questions, keep it informal and have a discussion too, but I know there's a lot of people on the line, and some will feel open to share their questions, and some will prefer doing it informally or one-on-one or by email. That's fine too, but it's really to hear some of your comments on those 2 questions that Cynthia asked, that slide number 18. That this is what we're asking people, and I think it's fair to say, yeah, we do want to put something together after listening to you here today. And this is, I know people think this is a one-time chance. It's not. What I call, when I've been around, I've been across our whole LHIN already once. I'm still working at getting to some corners. That's community engagement. When Dr. Preston, Terry, Kate, Cynthia, Cassie, or Richard go out in the community. I'll give an example of Richard. He's going out and meeting all the communities to talk about similar type of questions. So we have collected quite a bit of information already, so we're not starting from scratch. I want people to hear that too. But for me, it's important to listen today, hear your comments, most importantly, on those 2 questions.
Thank you, Jeremy. We do have our first questioner, so I'll give them a mic. And caller, your line has been unmuted. Please state your name and your question or comment.
I hope it's me. I don't know. My name is Anke Lansky-Johnson from Elliott Lake, from beautiful Elliott Lake. And my question is to your... Thank you. And thank you again, too, for supporting us. My question is to point 2, the last dot, strengthen system sustainability. Question or discussion we have had with other partners. We are in year 7 with no base budget increases. Is that what that would be addressing, that we could address our rising cost over the past 7 years in terms of not just wages but of everything? Will we see base budget increases of sorts?
Yeah, so thank you for the question. Great question. Hard question too. It was Mrs. Elliott, correct?
Say that again. I didn't hear you.
I didn't get Mrs. Elliott, correct? It was from. I just want to make sure I know who I'm talking to.
My name is my name is Anke Lansky Johnson. I'm in Elliott Lake.
From Elliott Lake, Mrs. Johnson Lake. Right, very good. I have my senior team on the line too, and that's one of the reasons why I want them to be able to respond to some of these questions that that people have. But so the purpose is, we're interested and concerned about the whole region. We're concerned about the sustainability of the health system. I don't know the details of what's happening in Elliott Lake, of course, but maybe I can turn to Kate to answer that one.
Thanks, Jeremy. And, recognizing that certain sectors haven't received base funding increases for a period of time, I think the challenge that we have is always wanting to ensure that we're putting the investments, the funding that we have to those areas of highest need. So certainly, part of the work that we'll do with our IHSP planning and the conversations that we'll have at each of the local tables is really focused around, where do we need to make investments? Is it in advancing a base across the board increase to all, or are we looking at sort of specific targeted investments? So we don't have a final decision on that today. However, I think we are hearing from a number of providers that it's become challenging to, do the same without an increase, and we're really wanting to ensure that we have that conversation with all to make sure those, those resources are directed where they're needed most.
And maybe I can add to Mrs. Johnson's point too. And the question is, I always like to return the question too, because our approach is a very strategic approach and priority focused. And I'd love to hear when I'm going out there and from around the table too, from those on the line, from Mrs. Johnson. And the question is, we have an opportunity here as we do this process to look at those things, to really focus any additional dollars, or if there's any reallocation dollars, to put it more towards the main priorities where we feel we'll get the largest impact, the biggest impact and change and improvement in healthcare. That's a great approach too, but I'd like to hear from those saying, maybe the best impact is to increase a little bit everybody's, funding and capacity. If that's what I'm hearing too, that's what maybe we'll change our focus. But I don't know if you have a comment on those two approaches, Mrs. Johnson, sorry.
It's not just for us here in Elliott Lake. It's across the sector that there were no increases. And the cost of living, and not just the cost of living, but retainment of staff. We have good staff, but when we are not unionized, and we wouldn't have the money anyhow to do that, then people leave us, and that then causes lots of issues as well. It's hard enough up here in the north to retain staff. We can't compete with wages in the bigger centers, and the rural areas are a little bit more challenging.
So your comments are heard, are noted here, and the CEO is hearing it. Let's put it that way, and it's a great comment. I think it's something that we could definitely look at. And by the way, thank you for being brave and being the first to ask a question.
And there are no further questions in the queue, so I'll turn it back to you.
Okay, I'm just going to ask, thank you, if there's a question online.
And we do have another question.
So there is a question that came online as well. How are we going to include invisible minorities, low-income, homeless, and mental health and addictions, multicultural patients in our efforts to serve the vulnerable sector?
Great question. So again, I guess we're getting a lot of questions here today, and I'm wanting to hear some of these answers to these same questions. I'll also call the vulnerable. The vulnerable has come at the forefront since I arrived here at the LHIN, of our priorities. It has always been there, but it's actually risen to the top in our concrete priorities for this last year of IHSP. I strongly feel I can speak before I meet with all the health service providers across the region and have our engagement events, but I think we're going to see that invisible minority, the ones that are vulnerable, the mental health, the homeless, the addictions, the Indigenous, the French language services, be at the top of our priorities. That's all I can tell you right now this time, and I'll hear from others. But what I'd be interested in more is, what do those questions mean, and how do you see us making a change, and what can we do to resonate in your communities around these vulnerable people?
And I would just add, I think that you'll see over the next couple of weeks, we do have a couple of announcements that we're ready to make, and I know that one of them has to do with how better to serve people who are the vulnerable population group, and establishing equity-type clinics within different communities across the Northeast. And with mental health and addictions, I don't know, Terry, if you would like to speak to that at all and the work that's taking place.
Hi, Cynthia. Thank you. So Terry Tilichek here. I'm the VP of Strategy at the Northeast LHIN, and I would just say that mental health and addictions is a priority and continues to be a priority. We've heard from the three parties now running up to the election about their interest in seeing continued investments in mental health and addictions for that vulnerable population. So we're really readying ourselves here at the Northeast LHIN in terms of working with stakeholders right across northeastern Ontario to prepare ourselves for those investments that will be coming our way to improve access, including the opioid strategy, which is already underway. Structured psychotherapy will be coming shortly. So yeah, I think that certainly has been a priority, and I would assume as we go out and talk to stakeholders across northeastern Ontario that's going to resonate with them as well.
And I'll just thank you, Terry. So that last question answers my question. I think I'll put check marks in front of my sheet here. When my question was, right now locally we're looking at priorities, and I want to find out if our vision resonates with those on the call. So that question for me answers that one very clearly around the low income, the homeless, the mental health. I'll put a check mark on that list. Indigenous health, French language services, multicultural was on that list. Mental health and addiction. So I'm happy to hear those. That's resonating everywhere I go, by the way. But that's the kind of the comments I want to hear today.
And we'll take our next caller now. And caller, your line has been unmuted. Please state your name and question or comment.
It's Paul Heinrich here. I'm not sure if it's me or not that's online.
Yeah, Paul, you're on.
Can you hear me?
Yes.
Okay, good. Well, thank you for that. It's really good information, and I appreciate what you said earlier, Cynthia, too, that it is very scripted from the ministry level. But I stress about trying to boil the ocean, and ultimately we really have to get to a point where we choose to focus, because we want to make sure we include every single conceivable care practice, provider, region. So we really have to include everyone, and what ends up happening is we can't move the bar because we're trying to do everything at once. So I think it's going to be a real tricky thing to convert all these priorities into something that we can actually achieve. So I would hope that the group keeps that in the back of their mind the whole time. Just looking at the list, for example, this list at the end here doesn't resonate yet because, again, it's so all-encompassing. For example, building capacity. For what? Everything? Do we not have to choose, one or two things that we're going to build capacity on? Because otherwise we'll just peanut butter our limited resources, and basically everyone will be equally unhappy. I think that we could learn a good lesson on this. I'm pleased to see there's a regional quality table representative. That group was really amazing. They came up with, actually I'm part of it, but there was the rest of the group that was amazing. They came up with a focus on transitions of care, specifically around home and community and long-term care and hospitals. And the process they went through came down to a very refined and clear plan of action that was pretty singular, and I'm really proud of them for that. I did also, I don't want to go on at length here, but I am very supportive of having the digital health as one of those key things. But maybe you could combine the concepts, like driving digital health to enhance care coordination, for example. And I've been sharing with you, as you know, Jeremy, that my desire to really move the bar on connecting all the providers in perhaps our sub-region, immediately following the implementation of the new technology at the acute center. And to me, if we focused on something like that, we'd actually be actively connecting. We'd be dealing with care coordination and investing in the technology. We'd be reviewing the handoff processes, because you have to do that in order to install the system. And it's something like that that would be game-changing. That it would be nice to see that kind of thing emerge from this exercise. And finally, I did want to point out that it'd be good to actually have some consideration to the sort of resource requirements that underpin this. For example, the technology investment and the health human resource focus, which was referenced by a previous contributor. And I know that Paul Preston, and now I'm on a new group that's tackling that. But that's something we really have to, I think, focus on, especially in our region. And that's one of the pressures you have as a provider with your home care staff, for example. You know very well that's something that's a real concern for the entire region. Thank you.
Thank you, Paul. That's exactly what we want to hear, is those type of comments. They do resonate with us, and the messaging when we're going out, we're hearing you today, and I think it fits well with the messaging we will be sharing as we go out and do a community engagement. It'll be interesting the reaction we get, but because I think it'll be well received, but we'll bring you back, we'll circle back, but that's exactly the messaging. We know we can't boil the ocean. We've tried that. I can say I've been on the other side of this phone call for many years, and watched as the LHIN has worked hard in trying to do so much, and maybe the time has come now to drill it down to integrate some of these priorities, maybe like you say, Paul. I like that term, and focus, like I said at the beginning. What are the top three areas? And yeah, some people will, some areas, or some sectors or departments, I don't know, may not be on the winning end of it, but at the end, we'll see the biggest change, the biggest impact in our system by turning to you and helping us identify what those big three top areas are. So, and also a comment about following investments to follow these priorities also needs to be there. We hear you.
Yes. Thanks
and
very
we'll
much,
Paul.
That's a great comment.
And caller, your line has been unmuted. Please state your name and question or comment, please.
Hi, it's Heather calling from the Red Cross, and I was glad to see your investments in both Indigenous health and prioritizing the personal support work. I think that's two things that hit close to home for me.
Mm-hmm.
I know I've been involved with, from the beginning when Michelle O'Connor had the original personal support strategic planning, and I just sometimes like to be involved in looking back on all the work that's been done and to see what worked and didn't work over the years, because it's still such a shortage, both in our First Nation communities, as said, as I'm sitting here in Saskatchewan today, and as well as throughout the region, throughout the province. I just wish that was something we could solve.
Well said, Heather. I've been out and about slowly, and I have a chance to talk to a lot of Northerners, and the Red Cross comes up so often how pleased they are in the service that you provide, and your comment resonates here loud and clear. I think we don't want to reinvent the wheel. We want to find out what's worked and what's not worked in the past, and I'm hearing that from a lot of our own staff saying, have you considered these priorities? Have you looked at revisiting this that worked in the past and was changed? So very, very open to that dialogue. Thanks, Heather.
And I just want to say, Heather, you yourself do amazing work along the coast, and we're very grateful to have Northerners like you helping us to move some of these yardsticks forward. And I know with our Reconciliation Action Plan and those 24 calls for action that you are making a difference in the work that you're doing. And we really value your partnership. So thank you.
It really helps, like even now as we're doing evacuation planning, just being able to connect all the resources and all the players in the north. But my favorite part this week was coming into the Sheshwan Health Center, and our Red Cross trained PSW jumps out and goes, "I'm Red Cross ready." Like she's trained a little on disaster service, I guess, along the way.
Great, thank you for sharing. That's great.
Thank you, and we do have another question. Oh, I'll let the caller go, and then we'll answer a question online. Thank you. Sorry, was there
another one on the line, or can we go to the?
Yes, there's another live caller. We can take it now, or you can.
Sure, let's do that.
Just stand by, and you can let me know. Okay, thank you.
Hi, it's Paul Shadley from the Mixed Group.
Hi, Paul.
Can you hear me? I'm not sure if I'm on or not. Okay.
Yeah, you're
thanks
on,
for allowing.
Where are you?
Okay, thanks for allowing us to provide input in your ISP. As you know, or may not know, we just finished our 5-year strategic planning here at the Mixed Group, and your priorities and your are certainly very similar to ours. So happy to see that. Just one thing that came out of our consultations is, certainly in terms of strengthening system sustainability, there is a crisis that's looming, as you can probably understand and appreciate. We have an aging population here, especially in the rural areas, and our working population is actually decreasing. We're facing a lot of staff shortages, RNs, RPNs, PSWs right now. So I'm not sure what the Northeast LHIN or the LHIN's role is in planning HHR, Health Human Resources, but it's going to be a real concern for all of us. So okay. I'm not sure how you would get yourself involved, but working with maybe the colleges with us and the NOSM group.
Right.
I'll stop there.
So, and I don't know if I'll take this is a big, complex question, and I think we could take the time and answer. But what I'm hearing, though, Paul, is that I guess I'm hearing loud and clear is some way, somehow, the LHIN strategic plan and direction should be find a way to address this HR crisis. And I'll tell you right now, I don't know if we want to give the line to Richard or even Kathy in Sudbury, but on that note, the PSW challenges and crises that we're facing right now has come at the top of our priority list and is on top of our concrete list right now to find a solution for that. I think we're finding solutions that, to be honest, I think are maybe short term. We need to look at the long-term impact, and like you're saying, it resonates loud and clear here too with us that aging population and a smaller workforce. So it's not a few strategies here or there that will almost band-aid the solution, but we need something that is sustainable. So I think noted, and we'll add that to the list, and as we go up to see what will be our role, and this may be, I wouldn't be surprised if this one comes up at the top of the list.
Okay, thanks a lot.
I wonder if, Richard, you wanted to speak to some of the work that you're doing within the PSW challenge that we're facing?
And the caller disconnected.
Okay. All right. We do have another question here. I will ask my colleague Terry Tilichuk to try and start to address it. I think I understand it. Can you describe, and thank you, Mariette Sutherland, can you describe how you will frame the priorities from the standpoint of intersectionality? For example, we know that mental health and addictions is a priority, but I'm interested in the intersection with Indigenous population health needs within mental health and addiction, rather than treating each priority as a silo of sorts. Are you still there, Terry? I'm wondering if our colleagues got disconnected.
I believe that that colleague has dropped, and I'll watch for them to dial back in.
Okay, something must have happened with the line. Jeremy and I can attempt to answer if I understand it correctly. Can you describe how you will frame the priorities from the standpoint of intersectionality? So I think that's the middle part of our name, integrated, and we talk about this a lot at our senior team and how we make sure that we ourselves are not building silos. I really like what Paul Heinrich said earlier about trying to merge our priorities together so that one is working hand in hand with the other. And I think with regards to the Indigenous population, when I think of what we've done within our Reconciliation Action Plan, and there are those 24 calls for actions that are being actively worked on right now, there are several that deal with mental health and addictions and how we get better at meeting the mental health and addiction needs of that population group, knowing that pockets of the population are in dire need of services. So I don't know that I have a strong answer.
No, but maybe I can share a little bit too. Yeah. I know the challenge, and those who haven't had a chance to work closely with them or standing in their shoes even, I'll share a little bit personal experience here too. You know, a lot of what we do is driven also by provincial and ministry priorities, and that's good in some ways. But the challenge with that is exactly that comment from this young lady. I really appreciate her comment from Mariette, is that when you do that, you create those silos. But that's where we come in, and I think the beauty of the LIN is to look at how can we put our own local flavor and integrate not just priorities, but integrate. I guess in this case it would be integrating priorities, but integrate in the local area. How do we address, be it you have an Indigenous person who's francophone, who has mental health or an addiction, and on top of that have issues with housing. Okay, so we don't want to treat that person in silos for those, for example, those three areas, but how do you treat them as a whole, a more holistic approach? And we're seeing that with the LIN, integrating our staff in the community, less siloed and providing care on a single basis. We're talking a lot more at the LIN too, and how do we provide care along individuals' continuum? We help deliver care now, so how can we do that? So I think those discussions are happening. Like Cynthia said, I'll just end with that, is that we internally are trying to do the same thing, is how can we look at how we deliver and how we plan care as an integrated entity and organization. So no, good question, tough one there, but I'll add it to the list of, I'll sum it up here in 2 minutes before we sign off.
And I know that our colleague Terry Tilichuk managed to get back on the line. I don't know, Terry, if you had any quick summary thoughts, or maybe we can go to the next question.
I could hear more from people here. I want to hear as many comments as we can today. So.
And we only have a few more minutes.
Yes. Sandra, is anybody else on the line that has a comment?
Not presently. I'm monitoring.
Okay.
There was another one that came in online. What communities will you be visiting during the summer for the IHSP engagements?
Great question. What communities are we not visiting? But no, I'll let Cynthia answer that one. We looked at the map of the North, and it is a challenge and I hate talking about challenges because I don't want to give excuses, but we have a summer to do this. I know we can do it, and I think we can be in as many communities as we can. So Cynthia, where are we going?
Yeah, and we're just finalizing the schedule. So I think between Jeremy and I and others, we've sliced and diced this many ways to try and get to as many places as we can over the summer. And we will be posting it to our website, I think, within a week. But Burkes Falls, Parry Sound, New Liskeard, Kirkland Lake, Espanola, Elliott Lake, Blind River, Sault Ste. Marie, Timmins, Chapleau, Wawa, Hornpain, Hearst, Kapuskasing, Smooth Rock Falls, Cochrane, Iroquois Falls, Mattawa, North Bay, Sudbury. That's a few of them. And Manitoulin will be on there. So there will be a comprehensive list on our website, and others may be added.
And for those that we can't, I think we need to. I was on the call this morning with my 14 other CO colleagues, or 13 other colleagues, and I was asking them, how do you reach out to your regions? And they recognize that we have one of the largest, and we're encouraged to use our technology and to reach out. We have some corners of the north that I will get to eventually, but we may not get to this or in this summer trip. But we will use technology to reach out to you.
And there is one more question, if I can, so we can try and smidge it in. I don't know if we're going to automatically get shut off or not, but it's Anki Lansky-Johnson, I think from Elliott Lake. Will that include support to health service providers and their IT issues? There was a pilot project started but was lost. Is it still on the radar to be resuscitated?
So those for digital health.
This is about digital health, yes.
Okay.
And I'm not sure. I think Kate Fife is back on the line. She can speak to a few of the amazing things that are happening within digital health. So
while Kate goes on, I think, Kate, can you share, I don't know how to share this without sounding repetitive, but digital health has come up at the top also of the top 3 list at the LIN right now, and investments and leadership has been secured to move that forward. So I think you'll see lots coming down on that on digital health. But Kate, did you want to add something?
Just to build on that, so glad to hear it coming up in the call today. Absolutely, it is a priority. It is one of our top priorities for the LIN. We are looking at the pilot that was considered, and right now looking at all of the digital health initiatives to be able to look at how best to move them forward and where those supports are required. So I think it is something that will continue to be a priority for us in this IHSP, and as well specifically to your question, we'll cycle back to give you an update on the pilot.
Okay. If there is no other, I know we promised to stay within the hour. Sandra, is anybody else on the call?
There are no further questions in the queue at this time, but you can continue speaking. You're not going to lose your connection.
Okay. I appreciate that. You never know. I will, maybe if I can just sum up what I've heard today, and if anybody wants to correct me, but what I heard today, where it resonates and where we're going is we heard about properly funding our health service providers, mainly focusing on making sure they're able to recruit and retain the good people that they have. We talked about focus to be on the vulnerable, the low income, the homeless, mental health and addictions. We heard on the need to be focused, to not try to boil the ocean, if I can use that expression from one of the callers, and to include everyone, but to put things that are achievable in front of us for the next 3 years. To look at integrating some of our priorities, and for investments to follow these priorities, and not to reinvent the wheel, but to look at what's been worked and what's not worked, and to consider as top of our list of priorities would be 2 areas, which is human health, HR crisis, human health resources, and digital health would be the 2. And one of the last comments I'll make is to maintain that local flavor as much as we can. So those were great comments. They resonate. None of them have not resonated with me, I guess I should say. But having said that, these are the type of exercises we want to further continue having to put together something that does resonate for all of us, and with the understanding that we will not be capturing everything, but we will be capturing what is the greatest need and the residents are greatest across the Northeast. So we commit to that, and we look forward to further engagement. Cynthia, any last words?
I think those were great last words.
Thank you very much, everybody.
Thank you.